Well, good morning, everyone. I make 11:30, so I think it's time that we start. Welcome to this session on innovation and technology. I'm Niall Eames from Belfast. We'll hopefully soon be joined by Tony Bateman. The first paper is from Ramesh Dalwai on the feasibility and costing study of bone harvest during lumbar spine surgery for subsequent use as fresh frozen allograft. So I'll hand over now and start that talk.
Good morning. I'm Ramesh Dalwai, Spinal Fellow at Royal Orthopaedic Hospital in Birmingham. I'm presenting a study which was done in collaboration with Mr. Marino, spinal consultant at New Cross Hospital in Wolverhampton, along with Mr. Mahmood and Mr. Hillis from University Hospital Midlands. So in this era where we have advances from various techniques and approaches to achieve fusion, we'd like to think about the graft choice in spinal fusion. On an average, we use about 20-25 grams of bone for fusion at each level of lumbar spine. You're all aware of the various options. The bone bank does give us an option to store the locally harvested bone. And the orthopedic community is well aware of this. So during the decompressive procedure, bone that is harvested is in a readily usable mosselized form, but unfortunately we throw it away. We decided to measure this bone per patient and look at the feasibility and costing involved in using this as a future bone graft extender. We work in a place where we had a well-functioning femoral head bone graft bone bank. The pilot study involved 3 surgeons, 2 different hospitals, prospective between October and November 2019, 20 consecutive cases, and 22 operative levels. Procedures included were lumbar decompression and discectomy only. A variety of techniques were involved, were utilized: over-the-top decompression, bilateral decompression, single-level discectomies by 3 different surgeons. On average, the bone harvested per patient was 4.1 grams. As expected for discectomy, it was much lower. So we decided to look at bilateral decompressions and over the top as a common pool, which gave us a bone graft yield of 5.9 grams. Next step was to look at the feasibility and costing. All the patients that give their bone for bone bank need to have bloods done and also donor swab from the bone, as well as for microbiological testing. Repeat blood tests are done at 180 days. The overall cost of this per donation is 94.3, which is significantly less than expected. However, as the bone bank was well functioning, we did not include the running costs of the bone bank in this. Next, we looked at the NHS-BT liver pool, which most commonly used are the freeze-dried coarse granules and the putty. 5 cc of the putty is most commonly used bone graft extender, which costed about 450 to 600 pounds, depending on the vendor. And these values were checked by the procurement team at the Royal Wolverhampton NHS Trust. So the bottom line is 1 gram of DBM costs about 71 pounds, which is nearly the same as 6 grams of harvested bone from spinal decompression. So in conclusion, 6 grams of bone graft extender in the form of decompressed spinal bone saves you about 350 pounds. Till date, on the BSR, there are more than 51,000 decompressions based on the annual report 2020, of which nearly half of them are discectomies. So if you extrapolate the amount saved into these patients, the amount of money saved for the trusts can be enormous, which can be utilized to fund other services. However, you need to consider a robust service, which includes consent for the donor and the recipient. You should also consider the acceptability and training of the pre-assessment clinic, the bone bank staff, in processing and handling these bone grafts. I'm happy to answer any questions. Thank you.
With a first question here is from Christine. Where does the bone come from when you're doing the discectomy procedure, Ramesh? No, Ramesh.
I think he's coming. Yes, there he is.
Hi, Ramesh. Can you hear me?
I can very well. Thank you, Mr.
Great. Thank you for your presentation. There's a first question is from Christine. Where does the bone come from when you're doing the discectomy procedure?
Christine, thank you for that question. The bone is basically taken off as a part of foraminotomy or fenestration. So it's not a massive amount as you would imagine. It's only the inferior end of the lamina, or if you have to do a bit of undercutting fastectomy to get to the disc itself. So it's not a lot of bone that comes out during discectomy.
Sure. Did you look at fusion rates at all, Ramesh?
We, not as a part of this study, no, we haven't. But this was just to see the costing process of it. I mean, if we were to use it as a service, we have to go through the ethical committee clearance and all of that. But allografts do have a good union rate, which is nearly as comparable to any of the other bone grafts that we use as extenders.
Certainly, I understand. But autologous bone graft would be free, wouldn't it?
Oh, absolutely, yeah. We're not suggesting this harvested bone is a replacement for the autologous bone graft. We are just suggesting that sometimes the bone harvested from the patient may not be sufficient during the procedure, and this is used as an extender, as an alternative to the demineralized bone that we end up using.
Yeah, sure. The last question Christine asks, do you know whether the cells isolated during these procedures are as effective?
I mean, the fresh frozen bone grafts have been well used in orthopedic procedures for joint replacement reconstructions and things. The cells as such, because they're frozen at minus 70 degrees, the cells as such are not active. And that is why there is no immunogenicity associated with this. But however, the proteins are active and they help in osteo integration and osteo, basically inside the bone healing.
Great, Ramesh. Thank you very much. We'll move on to the next one then. Thank you, Ramesh.
Thank you.
So the next paper is from Mark Macher, ultrasonic bone cutting device used in spinal surgery, a systematic review.
Hello, and thank you for the invitation to present at this year's virtual conference. My name is Mark, and I'm a core surgical trainee working at the Nuffield Orthopaedic Centre in Oxford. With the help of my colleague Mr. Shafefi, I'll be presenting our systematic review and analysis on the use of ultrasonic bone cutting devices in spinal surgery. We have no conflict of interest to declare, and no funding was sourced for this project. As we're all aware, high-speed rotary drills have long been the mainstay for bone dissection within spinal surgery. However, the close proximity of spinning parts to vital anatomical structures can result in a range of iatrogenic complications. This includes dural tears or CSF leaks, injury to surrounding nerves and vessels, and associated blood loss, sometimes necessitating transfusion. Also, the unwanted frictional heat and temperature elevations can result in thermal necrosis of bone, having detrimental effects on bone regeneration capacity and increasing infection risk. The theoretical reduction in these risks has been proposed with the use of ultrasonic devices, and having initially been introduced for use in skull-based surgery, the utilization within spinal surgery has become more commonplace. Here, we present a comprehensive summary of the evidence to date, including an analysis of other factors including influence on operating time and associated costs. A systematic review was conducted according to PRISMA guidelines, including an electronic literature search on Medline via PubMed and Embase databases, as well as the Cochrane Library. Studies that contained evaluation of the use of ultrasonic bone cutting device in any form of spinal surgery were included. Randomized control trials, case control studies, retrospective cohort studies, and case reports were eligible for inclusion. A total of 31 studies were included, evaluating 1,996 cases of ultrasonic bone cutting device use within various procedures. The most common procedures were laminectomies, followed by facetectomies and corpectomies. Of those studies evaluating a control group utilizing a high-speed drill, 1,978 vertebral levels were recorded operated on, allowing for comparison to over 2,500 vertebral levels operated on with an ultrasonic device. The average reported incidence of dural tears and CSF leaks across all procedures was 2.56% per operated vertebral level. This compares to the reported rates in the literature of around 3.5% for high-speed drills. In the 9 studies identified comparing the incidence with the control high-speed drill method, only 1 study reported an increase in dural tear rates, but this was deemed not statistically significant, with the remaining studies demonstrating an improved or equal low rates. Of all studies comparing blood loss with a control high-speed drill, there was an average 38.9% reduction in blood loss volume. This was across all spinal procedure types. However, apart from in one randomized control trial evaluating instrumentation, this did not manifest into a significant reduction in blood transfusion rates. One study evaluated the difference in temperature rise between the 2 methods, identifying a significant reduction in heat generation and thermal induction of bone necrosis. However, there was no convincing evidence in the literature of a significant reduction in postoperative infection rates. The literature demonstrated a variation in change in operation time, with a roughly equal split between an increase and shortening in operation time. This largely depended on the type of procedure and, crucially, surgeon familiarity between the 2 devices. Of those outlining technical tips and subjective opinion, there was an agreement on the improved single-handed maneuverability compared to high-speed drills. There was also no reported convincing evidence of improved postoperative pain. Finally, there was an acknowledgement across the literature regarding the increased costs associated with the use of ultrasonic bone-cutting devices. It was demonstrated that in more extensive procedures with high blood loss, the costs could be offset against the savings made with blood transfusions. However, this would heavily depend on the acquisition costs for each particular center and require high-volume operating. Ultrasonic bone-cutting device use within spinal surgery offers compelling advantages in operative outcomes, complication rates, and technical approaches. We believe further high-quality research, including randomized studies, are required to evaluate their use further in a variety of approaches. Thank you very much.
Saying? Because you said the blood loss is less, but that doesn't equate to reduced transfusion rate?
Evaluating. I'm sorry, I didn't catch the start of your question.
Am I misreading this, or are you basically saying, therefore, from this review, that actually, when you come to it, there isn't a big advantage in this because the reduction in blood loss doesn't transfer to reduction in transfusion rates? It's more expensive. It reduces dural rate tear, but actually you can't see an actual, on black and white paper, benefit to this. Is that correct?
So the reduction in transfusion rates only really manifests in more extensive procedures, especially with instrumentation. So if a center is only doing low volume procedures and more kind of minimal extent of operation, then they may not necessarily benefit from the reduced blood loss. But they would get the benefits of maneuverability advantages and other things.
Thank you. There's a question there from Rajat saying, any difference seen in using the different cutting tips, different types of tips?
There was no outline in the literature review on different kinds of cutting tips and this effect on the complication rates.
Okay, that's great. Mark, in the interest of time, thank you very much. We'll leave it there. We'll move on then to the next talk paper by Rory Gibson, the application of full spinal endoscopy for the treatment of thoracic disc prolapse and other pathologies.
Hello, my name is Rory Gibson, and I'm currently working on clinical development for long-term orthopedics at Aberdeen Royal Infirmary. and I'm going to present the findings of our literature review on the application of full spinal endoscopy for the treatment of thoracic disc prolapse and other pathologies. These are our disclosures. As you will be aware, the use of endoscopy for spinal surgery is increasingly popular, and in recent years its application to thoracic pathology has been of increased interest. This literature review aimed to analyse the available literature to determine the use and effectiveness of full endoscopy, determine the pathologies treated, and compare outcomes where available with those after open surgery. There are multiple surgical approaches to the thoracic spine pathology described in the literature and used in common practice. However, transforaminal and interlaminar are the two approaches primarily used during full endoscopy. We undertook a comprehensive literature search of various electronic databases using keywords applicable to titles and abstracts, and those articles not available in English were translated. Searches included all human studies between 2000 and 2020, excluding technical reports, abstracts, and those employing tubular technologies. 180 relevant resources were identified, with 31 studies meeting our inclusion criteria. Of these, 17 were patient series, with patient numbers varying from 6 to 92, 13 were case reports, and a further study where patients were randomly allocated to either endoscopy or an open approach is included as a cohort study due to the multiple limitations with regards to the methodology. In total, this gave 535 operative cases. Of the studies included, 20 used the transforaminal approach, 6 interlaminar, and a further 5 described mixed approaches. The operative time ranged from 48 to 250 minutes, was heavily dependent on the pathology present as well as the number of spinal levels involved, however, remained generally favourable when compared to open approaches. 21 authors described the use of analgesia and sedation as opposed to general anaesthesia to facilitate this approach. A variety of pathologies were treated, while the majority of studies described its use in treating prolapsed discs. A significant proportion have been employing full endoscopy to treat ossification of the ligamentum flavum and posterior longitudinal ligament of the spine. 4 further studies described its use for the treatment of discitis and tumour resection. Across the studies, various outcome measures were presented. 12 studies used a modified Japanese Orthopaedic Association score, with all presenting excellent, good or fair results. And where reported, there was a reduction in visual analog rating pain score for both back and leg symptoms by 78 and 75% respectively. The Oswestry Disability Index, when reported, showed an improvement from 61 to 19% post-operatively, giving an overall improvement of 64%. With regards to complications, these were generally low at 8% for the cases reviewed. There were 11 instances of dural tear, 7 patients required further revision procedures, 3 instances of neurological injury with a further 2% experiencing transient paresthesia or neuralgia. There were 3 document cases of epidural hematoma. These complications affecting 8% compared extremely favourably to rates of 11 to 39% published in meta-analysis of open procedures, but also when we look at specific complications as published by Brotis in 2019. So what can we conclude from this? Well, we've shown that there is good evidence of favourable outcomes when the full endoscopic approach to thoracic spine pathology is taken, with potentially less complications when compared to an open approach. Furthermore, the evidence base is increasing year on year, and especially over the last few years, we've seen an increase in the international adoption of this technique. The review was somewhat limited by the small size of almost all of the studies. However, the comparative open surgical cohorts are not much larger, which is probably a reflection of the relative rarity of thoracic spine pathologies and consequently the number of cases presenting to a single unit. It's probably for this reason that randomised controlled trials producing level 1 evidence were not available for review. However, hopefully the centralisation of spinal surgery to regional centres in the UK and across the world should allow the production of better quality evidence in the future. Thank you very much for listening, and I hope you enjoy the rest of the conference.
Rory, thank you very much. I see Tony's there. Tony, do you have any questions?
Apologies, I'm a little late managing the technology into this session, but no, a great talk, and you're right in identifying these challenges to cases such as this where we have small numbers. What do you see as the real value of these studies where you're summing up essentially quite poor quality data? Do you think it's valuable to do that, or should we be planning more extensive studies and trying to focus on that?
I can see Rory, but can't hear Rory.
Oh,
No, I apologise if
Hello?
that sounds a little negative, Rory. It wasn't meant as a negative thing. It was a genuine, inquisitive kind of. What are your thoughts on this? Sorry, Rory, put you on the spot. And now the technology is not working.
Can you hear me now?
Yeah, there you go. Yeah.
Oh, sorry about that. I don't know what was going on there.
Yeah. So I think I presume you could hear me, and a great summation of essentially what is small studies, relatively poor quality. Now, do you think what's the main usefulness in summarizing those sort of studies, or should we be focusing more on trying to gather better quality evidence? What are your thoughts on that? And is it feasible to gather better quality evidence?
I think at the moment the importance of focusing on the smaller studies is to basically show that there is purpose in gathering the better quality evidence. So I think we've proven it's kind of worth investigating further, and as it's adopted in more centres, it would be worth trying to do some more controlled trials and comparing open and full endoscopy directly, which would allow the production of better evidence in the future that would be more conclusive.
Yeah, because Mark Thomas was asking a question: are you really comparing like with like? Well, as we all know, some will require open. So are you really comparing like with like with like?
I suppose not. I suppose we're not directly comparing like with like the entire way, but we're kind of showing that when both options are available to you, it would be worth considering this as a less invasive approach that would have potentially lower complications. But I appreciate that in some circumstances with different spinal pathologies, you may in fact need to still use the traditional open approach.
Yeah, exactly. And the learning curve for both of them, that must be clearly a different thing as well. Both have their own learning curves, don't they?
Yeah, I mean, we're talking about quite different procedures, aren't we? And I suppose the learning curve for the spinal surgeons that are already using endoscopy for lumbar discectomies, etc., will be slightly easier than for those just transitioning directly from an open approach to the thoracic spine, because I understand the anatomy of the thoracic spine makes it a more difficult area to operate on anyway, due to the kyphosis in the spinal cord within the canal, etc.
Yeah. Roy, thank you very much. We'll move on to our next talk. Thank you very much indeed. So the last one this session is from Tanze Qiang, robotic assisted versus fluoroscopically guided approach in pedicle screw insertion, a systematic review and meta-analysis.
Good morning, everyone. My name is Dr. Ziqiang Tan, and today my presentation topic is robotic assisted versus fluoroscopic guided approach in pedicle screw insertion, a systematic review and meta-analysis. To begin with, the background of this study tells us that the pedicle screws have traditionally been implanted using the freehand approach, but the main concern of this approach is screw malposition, which can lead to significant neurological complication. In order to improve the accuracy, techniques such as fluoroscopy or navigation has been utilized. And recently, the introduction of robotic assisted technique has significantly improved the screw placement accuracy. Hence, we aim to compare all the relevant outcomes between robotic assisted and fluoroscopic guided techniques. As for the hypothesis of our study, we hypothesized that the robotic assisted approach has higher accuracy in screw insertion, lower incidence of facet joint violation, better intraoperative and postoperative parameters compared to fluoroscopic guided approach. Moving on to the methodology of our study, we first systematically searched for relevant articles in PubMed, Medline, Embase, and central databases. The inception was conducted until November 2020, and this was followed by title, abstract, and full text screening to assess the eligibility of the articles. After applying the inclusion criteria, studies that met the inclusion criteria were included for qualitative and quantitative analysis. As for the first part of the results section, we first look at the BritSpine flowchart. Initially, we identified 196 articles from the databases, and after applying the inclusion and exclusion criteria, only 28 articles were included for qualitative and quantitative analysis. As for the second part of the results section, we first look at the screw placement outcomes. In terms of screw accuracy, the robotic-assisted approach is significantly associated with better accuracy compared to fluoroscopic guided approach. In terms of screw revision, the fluoroscopic guided approach were associated with significantly higher screw revision required post-operatively compared to robotic-assisted approach. Similarly, similar trend was also witnessed in terms of facet joint violation, with fluoroscopic guided approach associated with significantly higher incidence of facet joint violation. Next, we look at the intraoperative parameters included in our studies. In terms of the intraoperative blood loss, the fluoroscopic guided approach was reported to have significantly higher volume of intraoperative blood loss compared to robotic-assisted approach. However, as for the operative time, both fluoroscopic guided approach and robotic-assisted approach were demonstrated to have comparable outcomes, and this might be due to the long setup time required in the robotic-assisted approach. On the contrary, the fluoroscopic guided approach is associated with longer intraoperative radiation exposure time compared to robotic-assisted approach. And similar trend is also witnessed in terms of the intraoperative radiation exposure dosage. Next, we look at the postoperative parameters. In terms of the postoperative hospital stay, the fluoroscopic guided approach is significantly associated with longer hospital stay compared to robotic assisted approach. However, no significant difference was reported in terms of wound infection. As for the discussion part, the 3D imaging system in robotic-assisted approach has higher precision compared to 2D imaging system in fluoroscopic guided approach, as the 3D imaging system can precisely identify entry point and trajectory for screw insertion. Furthermore, the higher precision achieved in robotic-assisted approach reduces the incidence of screw revision, which also leads to decreased operative time, radiation dose, and blood loss. In addition, the robotic-assisted approach offers image matching between patient and robot, which requires lesser radiation exposure dose and shorter radiation exposure time. In conclusion, the robotic-assisted approach appeared to be a safe and more precise approach for pedicle screw. However, as this is a relatively new approach with lower power and small sample size in some studies, we believe that more well-designed studies are required to provide better evidence for its benefits over conventional approaches. These are the references we use in our study. At the meantime, I'm happy to answer any question from the audience.
Tan, thank you very much. That's great. Tony, do you have any questions there?
So obviously you've looked at this studies in detail. Have you been convinced that this is the future of what we should all be doing? Do you think this is a useful technique that you will keep in your surgical toolbox? Or do you think it's just a phase we're all going through and we'll come on to something better? What's your opinion?
Okay, so my opinion on this study is that because previously navigation and also robotic assisted has proven to be higher to have high accuracy compared to freehand technique, and our studies show that the robotic assisted approach have lesser intraoperative blood loss, shorter length of hospital stay, and also lower radiation exposure and exposure dosage. So from this slide, I believe that the robotic assisted technique will be beneficial for the patient in the future.
I think we're out of time here. But thank you very much It's been an excellent session. We've got all technology very well. I think it's time to end this so we keep to schedule. Isn't that right, Laura? Okay, thank you very much indeed. See you soon.
Thank you very much, everyone. Bye-bye.
Yes, this session has now ended, and we will be setting up for the next session.
Thank you. Cheerio.
Thanks. Bye.